single yourself to me, ignore the
Got it. Okay.
equipment and all the interesting stuff. I'm sure someone's about to fall over behind me as well. But yes, nivolumab and ipilimumab. If you'd be so kind.
Yeah, so this was an exciting clinical phase 2 study looking at nivolumab with or without ipilimumab in patients with metastatic sarcoma. It was conducted through our Alliance Clinical Trials and Oncology group with support from the NCI and CTEP. And in this study, we randomized patients to receive the single agent or the combination agent. And we observed some interesting findings. First, the combination was actually fairly well tolerated. The incidence of grade 3 or 4 treatment-related adverse events was only 14% compared to 7% with the monotherapy arm. And in addition, we saw evidence that the combination was actually superior in terms of efficacy compared to the monotherapy arm. With the combination cohort, it was demonstrated that the overall response rate was approximately 16%. And in addition, the median overall survival for patients treated in the study was about 14 months, with 54% of patients alive at 12 months. And these were patients that were extensively and heavily pretreated. Over 60% of patients had received at least 3 prior lines of chemotherapy. And so it really forms a foundation to begin to explore these combinations further in the field of sarcoma. And really the challenge is trying to identify a biomarker that will help us predict which patients are most likely to benefit, and then ultimately deciding on future confirmatory clinical trials.
And you mentioned the grade 3 and 4 toxicity response rate and also the clinical response rate, both about, was it 14 to 16? It seems like a risk to take. Will you be, in the 1 in 6 patients who has grade 3, grade 4 toxicity, or the 1 in 6 who respond, and is there then an overlap of you'll get better but it's going to suck?
That's a great question. I think there is some suggestion in the field that sometimes when patients have adverse events to checkpoint inhibitors, they may be more likely to benefit. However, this has not been proven on this particular clinical trial and further in cohort of patients with sarcoma. So I think it's a point well taken. We always have to weigh the risks and benefits of each of the therapies we offer our patients. But ultimately, the metastatic disease, from my perspective, offers a bigger risk. And so good discussion with your patients in terms of what to look out for, and being proactive and recognizes those immune-mediated adverse events can really help us bring these treatments to our patients safely.
Could anything be done to improve the response rate if it's, priming the microenvironment, or you mentioned heavy pre-treating, bring this combination forward to second line, even first line setting, something to bring that up?
Sure, that's a great point, and I think that there is lots of interest in perhaps bringing patients in that have had less prior therapies. I think that's very important. I think we're aiming to modulate the microenvironment with ipilimumab at this point, but you raised the point as to, well, should we consider other combinatorial strategies in sarcoma? And I think the fact that we're seeing these response rates suggests that there's certainly more work to be done, and exploring other agents probably is something that